Multiple sclerosis is a tough disease, but there's basically three things you need to do when you're taking care of patients with multiple sclerosis. We've learned this in our MS Center through extensive research and follow-up of patients over many years. One, you need to be picky about the diagnosis. Two, you need to follow up patients actively to make sure what you're doing is working or to see whether or not it's not working. And three, you cannot blame every single symptom that a patient with MS has on MS. Those three are absolutely critical. I'll give you some examples here. One is that every year we see 5 or 6 patients who come in who are on the shots for MS and who turn out not to have MS. They turn out to have other diseases that cause their symptoms. For instance, the most common one that we see is sleep disordered breathing or sleep apnea, fatigue, and either neuropathy or a problem with the carpal tunnel with entrapped nerves as they go through the wrist. The second one is you've got to follow your patients actively and aggressively. We try to see our patients with multiple sclerosis every 3 months. We are able to get them in either the day or the next day after they begin having problems. We put them on a little graph. It's called the Multiple Sclerosis Functional Composite Graph that looks at their thinking, their ability to manipulate their hands and fingers, and their ability to walk. And in this way, we can assess whether or not they're getting worse, whether or not they're staying the same, whether or not we're treating the multiple sclerosis adequately and stabilizing the disease. There's not a cure, but we have many things that we can pull out of the quiver to treat that disease. Third thing is, don't blame everything on MS. We're the ones who found a number of years ago that patients with multiple sclerosis have a markedly increased incidence of sleep disorders. A lot of them have sleep apnea. A lot of them have increased motion of their limbs at night that disrupt their sleep. A lot of them have spasms at night. And you treat these all very separately, very differently. And what I always say to patients is you can treat MS till you're blue in the face. And if you're missing something else, like a urinary tract infection or sleep apnea or carpal tunnel symptoms or a pinched nerve in the neck, then you're not doing everything you can to maximize the quality of life of that patient. You know, it's at our institute, we try to live by those three principles. You might say, how is that different from the rest of medicine? It's not. That's the way medicine should be practiced in every single discipline. Now, it's nice that we have 5 clinical care coordinators and certified nurses that take care of research studies. We're doing 12 to 14 of those studies at all times, trying to give our patients access to cutting pharmacological treatments in multiple sclerosis, cutting-edge kind of therapy that's not available yet. It's nice to have a certified and accredited imaging program. It's nice to have a couple PhDs, master's level type people who do basic research using animal technology and other kind of cell culture technology in multiple sclerosis. It's nice to have all those things, and we have them. But the critical elements here are, one, be very picky about the diagnosis of MS, because you can do something about it if you make the right diagnosis. 2, you need to be able to follow your patients actively and change what you're doing if it's not working. And 3, you cannot blame everything on MS.